GR from devotees అందరూ అందరికీ నా నమస్కారాలు. Thank you for giving me this opportunity to speak here. I want to especially thank Shaila garu and Madhuri garu for giving me this opportunity to talk about this topic. My name is Dr. Akula. I work in Southwest in Atlantic Air Medical System. I'm a cardiologist and a electrophysiologist by training. And today we will talk about sudden cardiac arrest. It's not a common topic that we hear about, but it is something that a lot of people have misconceptions about. So my goal is to give you a brief overview about what sudden cardiac arrest actually means and how people have or suffer sudden cardiac arrest or sudden cardiac death. What is the underlying mechanism that leads to sudden cardiac arrest? And what we can do as a public to try to prevent, or what you can do when a patient has sudden cardiac arrest. And then finally, when these patients are either survive and get better and come to us, what can we do to them to prevent sudden cardiac arrest in future? So the first one is just giving a brief etiology or overview what it means. So this is the official definition of sudden cardiac arrest. It's a life-threatening emergency that occurs when the heart stops beating. So the basic bottom line in sudden cardiac arrest is the heart stops beating. There is no pumping function of the heart. And this can happen to anyone. It can happen in very young people, very old people, people who have heart disease, and a lot of times people we think who are healthy suddenly die. They may have had underlying heart disease that we did not know about, and then patients die. Usually, patient suddenly collapses, he doesn't respond, and then within a few minutes, if there is no appropriate resuscitation efforts done, the patients die. So that's what sudden cardiac arrest by the definition means. It's a event that happens suddenly without much warning. The medical definition for this is if you die within 1 hour of the symptom onset, meaning a patient will have chest pain or shortness of breath, and then within an hour if he dies, that's classified as sudden cardiac death or sudden cardiac arrest. Some people, as I said, may not have any symptoms and collapse suddenly. About 15 to 20% of deaths all over the world is secondary to sudden cardiac arrest or death. So it's a huge problem on a societal level that needs to be addressed. So first we need to understand what it is so we can address it. And who gets affected varies with time, but in general, older people with underlying heart disease, especially male more than female, tend to have this issue of sudden cardiac arrest. So there is this big misconception about what is a heart attack, what is a cardiac arrest. A lot of people ask me a lot of times, okay, my patient had a cardiac arrest, my patient had heart attack. They use it synonymously as one as the other. It's two different concepts. When you have a heart attack, the circulation that is happening to your, or the blood supply that is happening to your heart, there is an interruption in your blood supply, meaning there is a blockage in the blood vessels that are supplying blood to your heart. When that blockage happens and you have complete interruption of circulation, then you have a heart attack. That's what a heart attack is. While when you have a cardiac arrest, it's not a blood supply problem, it's an electrical problem. Your heart is beating at a very fast heart rate, usually going around 200, 300 beats per minute. Normally, our heart should be beating around 60, 70 beats per minute when you're resting. So when your heart goes into this abnormal, chaotic, rapid heartbeat, where the heart essentially stops pumping, that is cardiac arrest. And different reasons there are different reasons why you have cardiac arrest. So the next slide, we'll see some basic differences between heart attack and cardiac arrest. So in heart attack, as I said, the blood supply to a part of heart muscle is suddenly blocked, and then the patient has chest pain, then they have shortness of breath, you call the ambulance, they take you to the hospital. Usually, when you come to the hospital, they do an EKG, they diagnose you're having a heart attack. In most places in US, they take you to a cath lab and they try to put catheters and open up the blockage. And that part of cardiac treatment has really developed well in the last 30, 40 years. I think the survival of heart disease has improved dramatically because what has happened in survival of heart attack. Very rarely we see now patients dying from heart attack once they come to the hospital. They are very quickly resuscitated. The efficiency and the effectiveness with which the cardiac catheterization physicians perform this procedure is pretty amazing. The goal is to open up the blockage within 90 minutes from the time they come to the ER, which is what is achieved in most of the hospitals. And then what is cardiac arrest? In cardiac arrest, the issue is not reduction of the blood supply, but it's the heart stops pumping because there is no pumping function of the muscle that is happening because the electrical activity within your heart is not functioning normally. Now, heart attack can lead to cardiac arrest, and we'll talk about that, how it happens. So here the patient essentially collapses, he loses consciousness, he may have a agonal or gasping breath. And then if somebody is trained with CPR, he might start a CPR. If EMS comes, they may start resuscitation efforts and then shock the heart and get them back to what we call as normal. Here, I was trying what causes sudden cardiac death. What are the common causes that cause a sudden cardiac death? Again, the most common cause is having underlying heart disease from either having a prior heart attack or blockages. That's called the ischemic heart disease. By far, the most common cause that leads to sudden cardiac death is having underlying blockages or heart attack or bypass surgery. There are other conditions where you may have a genetic condition or a muscle condition which causes abnormal propagation of electricity within your heart that can also lead to cardiac arrest. In some patients, they may have weak heart muscle not related to having prior heart attack. Even that also leads to sudden cardiac death. So the underlying theme here is you have a heart problem, either your heart is weak or your muscle is not developed well or your electrical wiring is not well. All these things can lead to sudden cardiac arrest in different patients. I was trying to show this graph essentially shows that the incidence of age-assisted mortality has been increasing with heart disease and the cardiac arrest. And many different things that we do now hopefully will reverse this trend, including CPR and use of AEDs and modern medicine.
Can I ask a question?
Yeah. We can keep it very informal.
Right, okay. So if you really look at it from 2000 to 2020, overall, if the medical knowledge has increased, availability has increased, but at the same time, the mortality has increased. So I'm trying to understand the disconnect.
It's actually patients are living longer and older. So before we used to have people dying with heart attacks in their 60s, 70s, and all that. Now you don't see that that often. Most of the time they survive, they live up to 80s, 90s, and then eventually have weak heart muscle and then get these kind of problems. So even though, yes, we have made a big impact in terms of the mortality, in terms of related to myocardial infarction or heart attack, but still these patients are getting older and living longer and developing other problems later on.
Okay. And are people, is stress playing a role in the mortality? Are younger people dying more than what they should call?
So that's one question I always laugh about when they ask me about stress. It's very hard to quantify because everybody's under stress. I'm sure stress causes some problem, but if you have extreme stress, it can definitely cause heart problems. There are known cardiac issues called as Takotsubo cardiomyopathy, where patients come after extreme stressful event, they present as if they are having a heart attack. You do a catheterization, they don't have blockages, but their heart muscle is weak. And that is being described and known. So we know extreme stress causes heart disease, including sudden cardiac arrest can be triggered by extreme stress. Yes. So the next slide, I was going to, in the next couple of slides, I'm going to show some video which will explain a little more about what we talked about, and then we can dwell into it. So the people ask, what is the risk factors of cardiac arrest? The risk factors are essentially the same as what you have for having a heart disease. Like if you have diabetes, if you have high blood pressure, if you have a prior smoker, the older you get, the more risk of having sudden cardiac arrest because you develop underlying heart disease. If you have prior heart attack and a weak heart muscle, those probably are the most significant risk factors leading to sudden cardiac arrest. If you don't remember anything else, if you have a heart muscle that is abnormal and weak, then your risk of sudden cardiac arrest goes up. That's the bottom line. How you get that weak heart muscle, it could be because of a heart attack, or it could be of high blood pressure, it could be of many other reasons. But having that weak heart muscle increases your risk. Okay, mechanism of sudden cardiac death. So again, as I said, this is an electrical problem. There are many reasons why this electrical problem happens, but before we dwell into it a little more, I thought I'll give you a little background. What is a normal electrical activity in the heart? How does it look like? When you look at the heart, it has two top chambers, the atria, and two bottom chambers, the ventricle. The electricity in the heart goes from SA node, which is the normal pacemaker of the heart that we are born with. That's where the electricity is generated. It's in the right top chamber of your heart. From there, the electricity moves freely in the top chambers. But for the electricity to go down to the bottom chamber, it has to go through a narrow channel that is called the AV node, which is labeled as AV node there, AVN. That then regulates or directs the electric flow to the bottom chambers of the heart. Once it goes through the AV node, it can go through the electrical wiring and go to the right side and the left side. There is a well-defined electrical wiring that we are born with, which then propagates the electricity to both the ventricles. Once the electricity is propagated to the ventricle, then the ventricle starts contracting. So you need both the blood supply and the electrical wiring to work properly for the heart muscle to contract. Both goes hand in hand. And sometimes I tell the patient, hey, you have a room, and for the room to be functioning or your house to be functioning normally, you need both the plumbing and the electrical wiring to work. If one is not working, the other can cause a problem. In the same way, in the heart, you need the circulation, which is the plumbing, and the electrical wiring both has to work. Circulation is something we know a lot because we hear about heart attacks and blockages. Electrical wiring is embedded in the muscle. We don't see it with naked eye, and we don't hear much about it because it causes its own issues, which is not as common as having a heart attack. So how do we as doctors measure the electrical activity of the heart? It's a very simple test. I'm sure a lot of you heard about an EKG or ECG. So when you go to a doctor, they will check your blood pressure and everything. And if it's your first time, they might do an EKG. The reason they are doing EKG is the EKG gives a snapshot about the electrical activity of your heart. And this is a normal EKG where even if you don't know anything about it, you can see the big lines are going evenly spaced at a regular interval. And that's what you want to see. And each box has a time interval, and you can calculate the heart rate of the patient based upon how many boxes are there between the two big lines. So here the heart rate is approximately about 60 beats per minute. So it's quite normal. And this is what you want to see when you see an EKG. And we'll see some other EKGs and see how it looks when you're having certain cardiac arrest. So here I wanted to imbibe a video here, but it did not get on my PowerPoint, so I'm going to just show you on a different screen. Just give me a second. Because I think this video is very self-explanatory about certain character. The volume.
The heartbeat is controlled by the electrical system of the heart. This system is made of several parts that tell the muscle of the heart when to contract. The SA node starts the heartbeat, causing the atria, or upper chambers of the heart, to contract. The signal then travels through the AV node, the bundle of His, bundle branches, and Purkinje fibers. This causes the ventricles, the lower chambers of the heart, to contract. The flow of electrical signals produces a normal heartbeat. Normal heartbeats can be seen on an electrocardiogram, or ECG. Sudden cardiac arrest, or SCA, is an event caused by a problem with the heart's electrical system. SCA occurs when the heart suddenly stops beating due to abnormally rapid electrical signals within the heart's chambers. The heart muscle becomes unable to coordinate with the fast electrical signals, and it begins to quiver uncontrollably instead of beating normally. As a result, the heart is no longer able to effectively pump blood and oxygen to vital organs like the brain. The heart needs immediate treatment from an electrical shock, defibrillation, to restart the electrical system. If SCA is not treated within 7 to 10 minutes, it leads to sudden cardiac death.
Okay. So that video kind of summarizes what we were talking about. I thought having the visual of seeing the video is more easy to understand than just me talking. It reinforces whatever we were talking about so far. So I showed you an EKG before. This is a different EKG of a patient who's having chaotic electrical activity. This is how it looks like. And we see this in patients who are admitted to the hospital who are having some issues. Once we start seeing them, this is called polymorphic ventricular tachycardia. There are many different reasons why it can happen. The patient's bottom chamber in those few rapid beats are contracting around 300 beats per minute or 250 beats per minute. It's very rapid. Obviously, it's not pumping. If this continues on and it's untreated, whatever the reason for it is, then they can go into the next rhythm, which is the ventricular fibrillation. This is what the video was showing you, and the heart was not contracting. This is not a squiggly line drawn by a school child, but this is what your heart is doing when you're having ventricular fibrillation. So at this rate, the heart is not contracting, it's just going into a chaotic electrical activity, and this is how it's recorded. If this persists for a while, as they said, in about 7 to 10 minutes, if you don't resuscitate, they go into a flat line and the patients die. So a lot of times we think when patients die, the heart stops and they go into a flat line. That happens, not common. The most common mechanism how patients die when they have sudden cardiac arrest is they go into one of these rapid beats, which we call ventricular fibrillation or tachycardia. I'll show you an example. And then the heart stops. Before the heart stops, during those 7 or 8 minutes, is the golden time that you can resuscitate the patient and bring them back. Once you miss that window and they go into a flat line, it's very unlikely you'll get them back, and they may have residual significant brain damage by the time you get them back. So fibrillation is essentially a chaotic electrical activity, and this is one of the most common arrhythmias that causes sudden cardiac death. Now, what can cause this? Again, the theme is the same. If you have a weak heart muscle, whatever the reason is, that can predispose you to ventricular fibrillation. If you had a prior heart attack and a scar tissue, that can predispose you. Some people may have genetic disorders, and we'll look into that a little later. That can also cause it. And believe it or not, if your potassium or magnesium are way off, that can also cause it. I don't want to scare you, but if you have too much diarrhea or problems like that and you're losing too much potassium and magnesium, it can happen. In a young and healthy person, having very low potassium leading to this kind of major issue is rare, but can happen. The other type of rapid beat that can cause sudden cardiac death is what we call ventricular tachycardia. Here, instead of fibrillation where the electrical activity is completely disorganized, there is some organized electrical activity, but it is still extremely fast most of the time. The heart is going more than 200 beats per minute. And most common reason why this happens is patient has underlying scar tissue that creates these kind of abnormal electrical signals. And what causes the scar tissue? Majority of the time it's a prior heart attack. So somebody who had a heart attack 4, 5, 6 years ago, and you follow them with, and even if you look back at the studies that were done in early 70s, 60s, when they followed patients who had prior heart attacks for many years, they saw the majority of the patients die suddenly. Why are they dying? Because they are developing some kind of these rhythms because of the scar tissue that they have. And again, here is an example of the EKG that will look with ventricular tachycardia. Now, being an electrophysiologist, I deal with this all the time, every day. We have patients who come these kind of rhythms to the ER, we see them, we shock them immediately, and we do what we need to do. But this is ventricular tachycardia, as opposed to the other EKG where it was all squiggly lines. Here the lines are a little more organized. This is a patient where you still have time if they are stable to revive them and get them back. So sometimes the patient's heart rate may be only 150, they may walk into the emergency room, we see this. If they're not getting better, we shock them in the emergency room, get them back to normal rhythm. Because if you don't, then again they can, yeah, you can go to next. Again, they can go quickly into this rapid rhythm called fibrillation. And once they are in this rhythm, it's only minutes before you can revive them. With ventricular tachycardia, sometimes patients may do well for hours, and you may have time to revive them. But once they go to fibrillation and the patient is in a very chaotic rhythm, you have only minutes before you can get them back. Otherwise, it leads to what we call asystole or flatline. So this is what really happens when patients have cardiac arrest. It's not like the heart stops suddenly and there is no beating. Majority of the time you get these abnormal ventricular rhythms where you have a time to revive the patient before they go into complete asystole. In some patients, asystole or flatline may be the initial presentation, there their survival is very, very low. But if you have a ventricular tachycardia or fibrillation and you are able to revive the patient within a few minutes, they do really well. There is usually no residual damage to the patient in terms of brain issues. Right? So again, heart attack and sudden cardiac death both are connected very close to each other. I just was hearing a story right now. They were saying one of friends here unfortunately passed away. He had some chest pain, shortness of breath, and he died within a few minutes or by the time he went to the ER. So what happens when you have a heart attack? What leads to the death? Is when you have a heart attack, there is a blood vessel that is blocked. Okay, and imagine this is a muscle. With in about 2 hours, you'll start seeing that the muscle is getting necrosed. And within 24 hours, you'll see a huge area of necrosis or scar tissue that is developing. If you open up the blockage at 24 hours, this damage is already done. There's nothing you can do to survive or make this heart muscle better. So that's why within the first few hours of a heart attack, typically 3 to 6 hours, from the time you have a chest pain. Ideally, by the time you get to the hospital within 90 minutes, if you open up the blockage, there will be less likelihood of heart muscle damage. So if you have a heart attack and the heart attack is causing a blockage, you open up the blockage, there's no residual muscle damage, that's the best outcome you can have. So the sooner you get to the hospital, the sooner they open up the blockage, the better it is. How can this lead to sudden cardiac death? When the blood supply is cut off to the muscle gets electrical instability. And during that time, patients can go into ventricular fibrillation because that muscle is unstable electrically. And when they go into ventricular fibrillation, that's when they will collapse and die. That's when they need to be shocked and revived. So shocking is you're reviving them from the electrical issue. Doing the catheterization and opening up the blockage, you're opening up the plumbing issue. So they both could be interrelated, and majority of time they are. So what causes death when you're having heart attack is the blockage leading to electrical problem, leading to sudden cardiac arrest. So that's how things happen majority of the time. Just having the blockage itself causing your muscle rupture and causing death is extremely rare, very, very, very unusual. And nowadays with the modern medicine, as I said, you don't see huge heart attacks because most patients are brought to the hospital very quickly and the treatment is done in a very expeditious manner. So I talked about sudden cardiac death mostly in older people so far, heart attack, underlying heart problem, but this is a thing that can happen in a young person, and that's the tragedy of it. Because sudden cardiac death can happen at any age, and in younger patients, what causes sudden cardiac death is completely different compared to what happens in an older person. In a younger person, it's usually some kind of genetic disorder that they are born with. It can affect their heart muscle, it can cause electrical problems within the heart muscle, or the electrical wiring or the ion channels that the heart muscle work with are defective. That causes them to go into ventricular tachycardia and fibrillation and cause sudden cardiac death. In this country, condition called hypertrophic cardiomyopathy, that is the HCM, is the most common reason why young people die suddenly, and you hear about people in the basketball court, in the football court, so suddenly collapsing and dying. That's what is happening. They have some underlying disorder which has been undiagnosed or under-recognized, and then they die suddenly. In them, there are multiple other reasons. Again, I don't want to bore you. As I said, it's most of them are genetic disorders. Sometimes you may be born with abnormal coronary circulation that can also cause sudden cardiac death.
So what you talked about, some athletes, they are completely healthy, no
Yeah.
previous problem, and just after a rigorous workout, suddenly they collapse.
Right. I'll show you a little more about that.
Okay.
See what the underlying thing is. So,
Yeah.
so here is a echocardiogram, which is an ultrasound of your heart for people who know, where we go and take pictures of the heart. The right panel, just imagine and believe me, this is what is true. The right panel where I put LV is your left bottom chamber, left ventricle. Just look at the thickness. That's all I want you to understand. The thickness of that muscle that is there. And on the left channel where I put the LV and the arrow, look at the thickness. The thickness is very, very different. It's much, much more thicker on the left panel than the right panel. This is hypertrophic cardiomyopathy. There are many different types for what type of hypertrophic cardiomyopathy. When your muscle is so abnormally thickened, within that muscle, the electrical activity becomes very unstable. And that can lead to ventricular fibrillation and sudden death. So hypertrophic cardiomyopathy, I mean, unless you do an echo, you may not see it, or sometimes you may do an EKG and then you see it. So screening for athletes is a very controversial and debatable topic that is in medical profession. In Italy, where they have some of these disorders which are more common, all the athletes are screened in school age and everything by an EKG. In US, we don't have a policy to do an EKG for everyone, but that's something locally the communities or schools and they have to address and see what is the best way to address this for the kids. Because if you do detect them, then you treat them, then you can prevent a tragedy because you have a young person dying. That's really a tragedy that should be prevented. So simple physical examination and possibly an EKG in a young person is probably a good thing if you're not sure how you want to screen.
So if an athlete dies like that and he has a younger brother, then they should.
Oh yeah, absolutely. So once you have a sudden cardiac death in your family, you need a complete family screening to see what's happening. I mean, I know it's a tragic situation, but if the young person dies, ideally they should get an autopsy, so that will give a valuable information. Not only because that will be really helpful for the family, depending on what they find in the autopsy. And then instead of looking at 100 different things, they can really focus on what might be the possible cause. Sometimes it could be a genetic testing, sometimes it could be hypertrophic cardiomyopathy, they need an echo. And as you said, if a sibling dies, the other sibling, initial echo may be normal, but you may need a repeated echo or lifelong screening. Some conditions you may need lifelong screening as time goes on. So that's important. So that's why in a young person, this becomes a lot more urgent, and it also becomes more serious and tragic for the family. So there are many things that can cause sudden cardiac death, but these young people it's very dramatic. And this is not anything unusual. I just put few examples in the last 3-4 years or 5-6 years that have
Right.
happened of people who have collapsed and died, like Kentucky football player collapsed during tryout. High school track athlete in Kentucky died during the exercise. Italian tennis player died. Competitor. And the names that are big, I mean, one of them is LeBron James' son.
Yeah.
He had a cardiac arrest when he was doing, luckily he was resuscitated and then he survived. And for people who follow NFL, Lamar Hamlin
Yes.
for Buffalo Bills, he had this sort of cardiac arrest on the field. His condition was a little bit different. It's called commotion cordis, where he had an impact on the chest and that led to cardiac arrest. But he was resuscitated appropriately, and now he's a big advocate of CPR, AED, and all those things. So this is not uncommon, and this is very common. It happens, and when it happens, it's dramatic. Um, Hopefully, prevention is the best way. You want to prevent this before it happens. And let's see what are the other things we can do to try to help patients with sudden cardiac death. And this is where the role of public comes. Anyone who's listening, what can I do? How can I help? What is my role in trying to prevent sudden cardiac death? The best way you can help is to learn CPR and get trained in CPR, get trained on how you use AEDs. And the Congress has also realized that this is a major issue and there are major things that we need to tackle. So the Hearts Act, which was passed in 2024, has provided significant funding to train school kids to raise awareness in schools, to try to provide AEDs at school levels and community levels to try to address this issue. This act has few things that it's looking at. One is mainly AED access, and we'll talk about that in a little bit. Why is that very important? How to develop and train CPR and AED training for staff, students at schools and communities, and then in general build awareness about sudden cardiac arrest. So now with this act and the money there, you can reach out to your own communities and see what's happening in your schools. If they have AEDs, are they providing CPR training? If not, maybe that's something you want to bring up locally at your communities, because there is government funding available now to help with these kind of things.
So even local schools that clear.
I think so, yes, because the act was passed mainly to strengthen local communities and schools for these kind of activities.
Wow.
All right. First, though I'm sure this audience, majority of you all know what CPR is, but I just wanted to put this here. This is the key thing that you have to do when you see somebody unresponsive. If you see someone unresponsive, you call 911. You check and see if they are really unresponsive or they are just drowsed away or whatever, and then start your compressions and breathing, and then continue the cycle. If you are trained, you know you have to do 30 compressions and 2 breathings, and 30 compressions and 2 breathings. If two of you are there, then you continue the compressions all the time, and the other person that's breathing in between. So that's the best thing that you can do if somebody has cardiac arrest or collapse, to try to keep them alive. So how does the CPR help? I mean, what are you doing that helps? When you do the CPR,
One question.
yes,
I heard that breathing into the patient,
right.
they discontinue.
Yes.
Is that correct?
Yes. I didn't want to get into the details.
Okay.
So you want to do, if you have, ideally you want to do it with a mouthpiece. That is the recommendation. So you want to do mouth-to-mouth breathing. So that's been discontinued. But the hope is by time the EMS comes and they can take over. But if you are not able to, if you have a mouthpiece by which you can do it, then that's fine. But mouth-to-mouth breathing has been discontinued. Yes.
And one other
If
question, if you have AED,
Right.
would you do the CPR first or would you do the AED first?
Right. So I'm going to come to that in a
Okay.
second. Yes. So I did not go into a lot of details about CPR AED, but we'll go through some of them, because then that's a whole topic by itself.
Right.
But when you are doing CPR, the key thing is your compressions. The compressions have to be very effective. That is what supplies the blood to the brain and your heart while other things are happening. Okay. So as soon as if you are only one person there, you start the compressions. and the compression is giving you blood to the brain and to your heart. And the compressions have to be high quality compressions. That's why I think going through a CPR training will really help. And you also need to know where exactly in the chest you want to compress to get the high quality compression. If you are able to provide oxygen and you are able to provide other things, that's fine. Usually for us lay people, when we somebody collapse, we will not be able to do all that. All we can do is the compression. And if you are lucky, we can do some breathing if you have a mouthpiece till the EMS comes. So to answer your question is, when you do AED, I mean, if there are two people there, you start the compressions first. One person, the other person goes and gets the AED and connects the AED. If it's only one person, and then I don't want to misquote, but the thing says you do compression for a little bit, go and get the AED and then connect it and then check. But ideally, you want to first call 911, ask for the help, start the compressions immediately as far as possible, and then you go and connect the AED. So the role of AED is very, very, very important in cardiac arrest because of everything I said before. Because what is causing cardiac arrest is those abnormal rhythms, the ventricular fibrillation, the ventricular tachycardia, before it goes to asystole, meaning flatline. Before you get the flatline, you have this very disorganized electrical activity. Those electrical activities can be shocked. And if the shock is effective, you can get back into normal rhythm, and the shock is usually very effective more than 90% of the time. So when you look at AEDs, the AEDs have become very simple, smart. There is not a whole lot you have to do. They have a pads, they have battery source, and they have a microprocessor that analyzes the rhythm. So when you take the AED and the patient is collapsed, you connect the pads, you turn it on. Everything is actually there on the AED itself. It will make you go through the steps. But it's always nice to get a formal training so you know what to do because in a situation of stress, a lot of times the mind is not working as calmly as it should, and you may be looking for the pads, you may be looking at the connections and all that, and get confused. So having some familiarity about AED would be good. But once you connect it properly, it will analyze it and it will tell you, okay, I'm going to shock now. Stop, move aside or stop, and then it will shock. Once it shocks, you are supposed to check the pulse and analyze the patient. If there's no pulse, again you start the compression. So in an ideal world, one person is doing the compressions all the time. The second person is connecting the AED. Once the AED is all connected, you stop the compression for a little bit for the device to analyze the rhythm. If the rhythm is shockable, it will shock the rhythm. As soon as you shock, you check the pulse and start the compression if there is no pulse. And the cycle goes on till advanced people come and the ambulance can take over and things like that. But the AEDs is what has made a huge difference in survival of certain cardiac arrest in communities. Like LeBron James' son, if he survived, or Lamar Hamlin survived, they survived because they were able to get shocked immediately and they were able to get back to normal. So that's why now you see AEDs in a lot of places. In the airports, in the casinos, in a lot of places you have AEDs. Is for this reason. So we say time is muscle in a heart attack. Here is also time is brain when you have cardiac arrest, or time is life when you have cardiac arrest. So you have that golden 7 to 8 minutes. By the time the person collapses, you put the AED, shock them. If you shock them in time, they haven't had any significant brain damage or anything like that. They will be able to come back and hopefully lead a normal life depending on what caused the cardiac arrest. Okay, so having the AEDs has been a game changer. I think that's one of the reasons the Heart Act that was passed by the Congress was big on CPR and AED training with the athletes in the college, in the school, where there's a lot of competitive athletes that are playing all the time. Okay.
I have a question. Doctor.
Yeah, please.
So any legal implications for a non-professional common man attempting to do the compressions or AED?
No, I don't think so. If you have a person who's collapsed and is on the road and you do it, I think there's no legal issues as far as I know. I mean, if
You are
you're on the road,
protected
you
by
are
good
not.
Samaritan
Right,
law.
you're protected. I was about to say that, yes. So you're protected by law to do that, as you said, Good Samaritan law. I mean, AEDs when you're on the street, it's obviously you may not have access to it unless you're carrying it in your car. But if in a facility you have AEDs, then I'm assuming you bought an AED because you got trained in it and some people know how to use it. And then you connect it and you try to do what you need to do. It will be life-saving for sure in majority of these cases. So the way the AED worked, as I said, is it first analyzes the rhythm. So you really don't have to do any thinking. It's all done by the machine. and he will tell you, hey, shock is advised, I'm going to shock, please move clear of the patient. And it will do the shock and then it will tell you what to do next. So it's very step-by-step process. It's a very easy process. Anybody can do it once you get trained on it a little bit.
Question. So we have an upcoming say consecration ceremony where 500 people can come. Do you suggest that we should have an AED during that time?
So, I mean, as you said, we are also having some meeting coming up, as I have said, should we have an AED? I think it's always nice to have one because you're having multiple people in one
People
place.
are there, yes.
And a lot of our folks are elderly folks with underlying issues. So having one in an organization of this magnitude where you get few hundred people at one time is not a bad idea. We are looking into it ourselves, and in the next meeting we are having, we already designated a room for EMT and CPR because we'll have about 800, 900 people in one place.
Okay.
So I think it's always a good idea to do it. Yes. And you should look into your township to see if the township can help too, because if there is something that can do. Our hospital, it supplies AEDs every year to in and around places
Mhm.
because we do a fundraiser every year to do it. So maybe there is something available locally.
So the Atlantic here, yeah, okay.
In the Atlantic County, Ocean County, we support local schools
Right.
and organizations where we donate AEDs to them every year
Mhm.
as part of Heart Health. That's done in February every year. So maybe there is something available locally here that you can look into, and it might be something you can
That's
do.
a good idea.
Yeah.
Actually, the closest one is virtual.
Virtual
Yeah.
Wellington.
Yeah, you should try and see, approach them or even your township and see what they say.
Okay, great.
So far I said things that what happens to sudden cardiac arrest, what you can do, and once you have done or the EMS has survived, came and the patient has survived and they come to us, that's when my role as electrophysiologist, as a cardiologist comes into play. This is where I take over and try and decide what can I do to this patient to prevent future problems. That's where the concept of internal cardiac defibrillators or ICDs for short comes into. So what is a ICD? What is the story behind it? There's a very fascinating story. Here is Dr. Martin Moore and Michael Morawski. They were in Mount Sinai, but Martin Moore, who is on the left side, the bald head, his story is very interesting. He was in concentration camps in Poland, and he escaped the concentration camp. I think all his family probably died or perished in the concentration camp, but he escaped. His father's dream was he should become a doctor. He did a lot of different works in different works in restaurants, everything else. Ultimately made it to medical school, became a doctor, went to Israel and started practicing in Israel. While he was practicing there, his mentor died suddenly. And that was his exposure to sudden cardiac arrest. And we knew there was external defibrillators at that time available that you can shock. But his mind was stuck into the concept that if I had something in my mentor's body that could shock him, maybe he could have survived. So he started visualizing this concept of having an implantable defibrillator where patients can be saved. And his dream, he thought, will not be fulfilled in Israel, so he came to US to pursue his dream. So a lot of perseverance. I don't know if any young people are listening. If they are, if you have an idea, a lot of times there's a lot of obstacles comes when you come with a good idea. Whether it's medicine or in real life, that's how life is. But you have to pursue. You have to go on. He pursued for 20, 30 years to get to his dream. So he came to Baltimore and he worked in a small hospital called Mount Sinai Hospital in Baltimore. And at that time, he was not well known in cardiology. In fact, one of the leading cardiologists wrote a scathing editorial saying this is a stupid idea.
Oh, goodness.
And then one other cardiologist, after a few months, wrote another editorial saying, no, this is a brilliant idea, we should pursue it. So there was a lot of debate within the cardiology community that pursuing an internal defibrillator was not a good idea. And it took them almost 10 to 15 years of their research in their own lab, with their own resources, to come up with some form of internal defibrillator. And they implanted in them in the dogs initially. And they showed how dogs got shocked and survived in one of the meetings. Half the people believed it, half did not. But that's the story. And that's a real story. It's not, and it's all documented. A lot of things in medicine, in fact, in life, you will see happens with perseverance and grit, and you just have to stay with it despite all the odds that come against you. You can go to the next one. So their hard work eventually led to implantation of first 3 ICDs in 1980 in Baltimore. These defibrillators were very big. They were implanted in the abdomen. You had to undergo open heart surgery. They had to put a patch on your heart. So it was a big deal, but those 3 patients survived. So with the shocks, and that led to this journey of ICD being developed. In fact, even the industry did not support them initially. Some others came and supported them. So from there, the ICD story over the next 20, 30 years developed with contribution of a lot of eminent scientists here. I'll show you the names here. But so initially, the ICDs were implanted in the abdomen, the leads were placed on the heart, you had to have an open heart surgery. From there, now we have come to an era where we are able to implant the ICDs under the skin on the left side of your chest, and the wires go into your heart, and it's a much smaller device, and the procedure is very minimally invasive. It takes an hour or less to do it compared to an open heart surgery that was happening in the beginning. So ICDs have revolutionized how we treat sudden cardiac death, and this picture gives an evolution of sizes of ICDs over a period of time. In this country, Medtronic, Boston Scientific, and Abbott are the three big companies that make defibrillator. They're all very effective. Which one you use, it really depends on what you get trained with and what you think is right for the patient.
This is one of the things you do on a regular basis.
Yes, so this is what my life involves. Half of my life involves with doing these kind of procedures. Yes, but
So I think I ignore my.
no problem. No question is a stupid question. Go
What
ahead.
is the pacemaker does and what does
What is
this
the defibrillator does?
defibrillator
Good, yes. So I'll explain that to you. So the question was, what does the pacemaker does? What does the defibrillator does? So let me tell you what a defibrillator does in the next one or two slides, and then I'll tell you what a pacemaker does. So as I said, the defibrillator now is implanted right under your skin on the left side of the chest, majority of them. And the wires go from the defibrillator through the blood vessel into your heart. You can put one or two wires, one on the right top chamber, one in the right bottom chamber. Some people need one wire, some people need two wires. Then there are patients who need three wires. So there are different types of defibrillators that we implant depending on underlying condition. Okay, so and now close to 150,000 are implanted in US annually, defibrillators. So how does a defibrillator work? So it's a very sophisticated computer. It's a very sophisticated computer, and the battery life now is almost 10 to 12 years once you implant it. After 10 to 12 years, you have to replace the device with a small surgery. So it's monitoring your heart 24/7. It's looking at each and every beat of your heart, and it's analyzing every beat. So if your heartbeat goes from the first three beats are normal, then it will be a very rapid beat. Within few seconds, it detects it and it has to make a decision: is this an abnormal beat or not an abnormal beat? Once it determines its abnormal beat, it tries to, most of the modern defibrillators tries to stop this abnormal beat by what we call as overdrive pacing or anti-tachycardia pacing, meaning it is trying to stop that ventricular tachycardia without giving you a shock, which is beneficial because then you come out of it without getting a shock because the shock can be uncomfortable. So here the device has tried it a couple of times, still went on, then it delivers a shock here. Here it's labeled as 40 joule shock and the patient comes out the normal rhythm. All this happens within few seconds. From the time the patient goes to ventricular tachycardia or fibrillation, by the time the device detects and the shocks will all be probably less than a minute. Again, this depends on how you program the device, and that's where we come into play. Where we want to detect it, at what rate, how many seconds into it, how do we want to treat it, and what pacing rate, and how much shock to be delivered is all programmed by your cardiologist in that device. And in each individual, the programming may be different depending on what is happening to the patient. These devices are 99.9% effective, most of them are 99.95% effective in getting you out of this ventricular apnea. So ICDs have made a tremendous change or been a game changer in terms of treating sudden cardiac arrest or sudden cardiac death in appropriate patients. Okay.
So
And now, yeah, go ahead.
All the settings that you decide as a cardiologist, is it more of a science or is it a science plus art? With experience that it comes, it's like
Yeah, medicine is always science plus art. I think a lot of it, like many things in life, it comes with experience. But so how you program, a lot of the programming is default programming based upon a lot of trials that have been done to see how it should be programmed in a given set of patients. So there have been trials that have looked at how many seconds it should be waiting, how much pacing should be done, what is an optimal time to wait before you get a shock, is shocks good or not. So there are a lot of science behind this to get to this. But in an individual patient, we change the settings if one thing is not working, depending on what we find might work for that patient. So if somebody, the 40 joule shock is not consistently working, that's the maximum shock the device can give, then we have to look at why is it not working, try to correct those issues. If it's not working, maybe put additional wires if we have to. So that becomes more a nuanced thing that you have to deal with patient to patient. Now coming back to her question about the pacemaker, so I don't want to confuse you, but all the defibrillators, I'll go to this in a second. All the defibrillators can work as a pacemaker too. And that's why it's saying here, pacing here in the fifth one. A pacemaker, what it does is it prevents your heart from going slow. So it is pacing your heart at a certain rate, and it keeps your heart, it can keep your heart pacing between certain beats that you program it to, but it doesn't shock your heart. The one that shocks your heart is the defibrillator, and all defibrillators by default have pacing function built into it. So they can work both as a pacemaker if need be, but their main function is to shock your heart. While you have a pacemaker, somebody gets a pacemaker, they are getting it mainly because their heart was going slow and they're treating that slow heartbeat by a pacemaker. And there are many different reasons why that can happen. So that's the main difference. So pacemaker doesn't shock, defibrillator will shock. Okay. So this was good. We have defibrillator now, we showed in 1980s it's working. Then again, as I said, there was a lot of debate whether this will work or not in the cardiology community, whether we should use them or not. So they took patients who had sudden cardiac arrest and they did a study. So there were simultaneous studies done in Europe, Canada, and US. This is a US study. So people who survived cardiac arrest, half of them got defibrillators and medications, the other half got medications alone. And this was the landmark trial, which showed, it's the AVID trial, which showed that people who got defibrillators live longer. And this led to the approval by FDA of defibrillators in patients who had sudden cardiac death in US. So if you have survived sudden cardiac death and there is a reasonable life expectancy and you are a good candidate, then you get a defibrillator nowadays. This is called secondary prevention, meaning patients already had cardiac arrest, they survived, and they came and they got a defibrillator. But when cardiologists were looking at patients at that time in their 80s and 90s, they saw patients are having MI, they're going home, as I said, more than 50% or more will die with sudden cardiac death. So when you have a sudden cardiac death, as I said, time is very important. If 10 people are having sudden cardiac death, only one is making it to the hospital. The survival was very, very low because it's very hard for EMS to come within 7-8 minutes to any place and revive the patients. So then the cardiologist started thinking, okay, how can we identify patients who are going to have sudden cardiac death before they have it? Because we are losing 9 out of 10. How can we identify them? How can we treat them? And there was multiple researches that were done, but I'll just go to the bottom line and tell you. So then, correct, you can go to the next slide. So this slide shows what we call primary prevention landmark trials that happened in US. So these patients are patients who did not have sudden cardiac death, but they had weak heart muscle. They took patients with weak heart muscle. There's many other criteria, but if you remember that, that's enough. And they said, okay, this is what seems to predict sudden cardiac death, and they took patients who have what we call ejection fraction below 35%. Normal is 50 to 55%. When we say ejection fraction, that is the pumping function of your heart muscle. When your heart muscle is weak and it's gone below 35%, there they have implanted defibrillators plus medications in one group. In other group, they gave only medication. And the group that got defibrillators survived longer. So based upon trials like this, now we say, okay, if you have heart attack and you survive heart attack and you have a damaged heart muscle and it's not improving, we recommend getting a defibrillator to prevent sudden cardiac death. So this is called primary prevention. And this probably is the most common place where we do the defibrillators now, before the sudden cardiac death happens, to prevent them from having sudden. So it made a big difference. I mean, the circle is coming around now. There's new trials going on to see the relevance of ICDs in modern medicine. I think that will take a few years to come. But for now, here and now, the treatment for sudden cardiac death, if you survive and you meet the criteria, you get an ICD plus medication. If you had a heart disease and you had heart damage for any reason and your heart muscle is very weak, then we might recommend a defibrillator to prevent a sudden cardiac death. So that's where modern medicine is right now. We talked about this primary prevention and secondary prevention. That's where the defibrillators are implanted nowadays. And we will go to the next one. And in the rest of time, I'll go through it. Defibrillators are also evolving. The first set of defibrillators that came out in the market were the ones where we put the leads into the heart. And there are potential issues, they can have potential problems as time goes on. So people have come up with this concept of putting a defibrillator in your axilla and having the wire under your skin so the wire doesn't go inside your heart. This is called subcutaneous defibrillator, where you put everything outside, it's a shock box, has less complications, and it just acts as a shock box and gets the patients out. The second generation of these by different companies, again, where you put the defibrillator but the wire, instead of being above the sternum, is between your heart and sternum. There are technical reasons why one may be better than the other, but this is how the field is evolving. Last year in Nature, there was a publication where they published where they had a pacemaker the size of a rice grain that they put in the heart. But we now commercially implant small pacemakers directly into the heart. They are available commercially, we do it all the time. They are called leadless pacemakers. But now they had a pacemaker which was the size of a rice grain implanted into the heart, came from Northwestern Chicago. And it's still in trials, but that's for pediatric patients. But that's where science is going. I think all these ICDs will be miniaturized as time goes on. They'll either be implanted under the skin or you may implant it directly in the heart. They will be quite effective. And who gets the ICDs will continue to get refined as modern medicine evolves with the newer treatment modalities that we have.
So the battery life is about 12 years, right? So
For the regular,
regular one, but if it's smaller the size, then does it
that's
have the
where,
same life
I don't know,
or
that's where I think that's the main thing, right? You want to have a smaller device, but the
you have to have
battery
a
life.
longer lifespan?
Yes.
Yeah.
So the newer pacemakers, which are now the leadless pacemakers, that's what we call. Even pacemaker also you normally implant in your chest with wires inside the heart. But now I can put a pacemaker directly inside the heart without any wires. And that battery life is still, depending on how much you use, about 8 to 9 years. Some of the newer ones can up to 10 years. So the technology definitely is there. It's only going to get better.
We have a couple of questions. Should
Yes.
should we read or
Oh, from
wait?
the audience?
Yeah.
Yeah. You can, please.
One question is, what are restrictions for patients with ICD?
Yeah, so once you get an ICD, for first few weeks, there is some restrictions for the healing process to happen. But once that has happened, the restriction is mainly related to your underlying heart disease. If your doctor is saying your heart is too weak, don't do exercise, don't lift any heavy weights and things like that, that's because of that. For an ICD, there is no more major restrictions. You should be able to do most of your activities. One major restriction that can happen for some patients is you cannot have commercial driver license. So if you are a truck driver or having commercial driver license, once you have an ICD, they will revoke that license. So that is one thing. But otherwise, normal day-to-day activities you should be able to do. Some kind of welding we tell you not to do, but otherwise normal day-to-day activities you should be able to do.
One more question is, how can we save people in remote villages in India? And please give your valuable suggestion, and thank you so much for letting us know to save a person.
So in India, medicine is also growing a lot, right? I mean, now we have ambulances that are there in majority of the cities that can do these kind of things. ICDs are quite prevalent in India in majority of the cities. In the villages, obviously, it's a challenge because you will have to rely on the mobile units that are going there to try to educate them. But to have AEDs and all that in villages will take a huge endeavor, and that has to happen both at the government level and NGO level. It's not going to be just government alone doing it. It has to be a combination of it. And I think the good and bad news is there are a lot of people like us here who all want to do something for our country. And there are different people who are doing it in different ways. Some are building schools, some are doing hospitals. So hopefully this process will continue to evolve, and India will also continue to benefit with the technology we have. The good thing with India is whatever they do there, they do it much cheaper than what we do here. So a lot of the production can happen at a cheaper level, at a much more easy. And I think that will make it easier to disseminate a lot of these things. Because cost is always an issue here, manpower is always an issue here. And we don't have issue with manpower in India for sure. The cost can be scaled down very easily there.
Who is not a candidate for ICD?
You and me are not a candidate. We are healthy. So anybody who is healthy is not a candidate. The only person who is a candidate is if you have a heart problem and you have heart muscle issues. Majority of the time, you have underlying scar tissue or a weak heart muscle. That's why you're getting an ICD. In a younger person, as I showed you before, you may have a genetic issues that is causing problems for your heart. Then you'll get an ICD. And in a younger patient, to answer the question from before, depending on their genetic condition, they may have restrictions. Some genetic conditions prevent you from exercising, doing vigorous exercise and things like that. But that's because of your underlying condition, not because of your ICD.
I think I'll continue because we're doing question. It's my question.
Right.
So right after COVID, we hear a lot of young people suddenly dying. They're suspecting either it's a cardiac arrest or heart attack. Like, is there a relation with the COVID
Yes.
and what?
So whatever may be the cause, when you have cardiac arrest, the ultimate thing that is happening is you're going into VF and you're going into a system.
So COVID.
So in COVID, what happened is you can get inflammation of your heart muscle. It's called
Nice.
myocarditis, that's the technical term.
Mm.
That can be either caused by the infection or sometimes by the vaccine. It can happen actually with any virus, but during COVID it was seen more. When you get inflammation of your heart muscle, you can get VTVF and all that.
Okay.
So some patients probably were getting that and dying from it. Some people might be getting heart attacks and dying because there was increased risk of clot formation seen during COVID,
For
leading to
thrombolysis,
stroke,
Cytokine
leading to
surge,
DVT,
yeah, same
leading
thing.
to
The
pulmonary
strokes is
embolism.
one.
One more question from
Sure.
risks and success of ICD insertion.
So ICD insertion, I mean, we should be able to implant in any patient who comes to us, unless there is some vascular problems that are there. Even that, now we can put a subcutaneous ICD. So there is really no patient that we will not be able to implant. The patients that we won't implant is if the patient is very sick, the expected lifespan is very low, or they have advanced cancer, things like that, or advanced dementia, then we don't want to do it. Or patient doesn't want it, or family doesn't want it, then we may not implant it. The complication rate is very low. Risk of serious complication is less than 1%. Some of the common complications you can get is infection, you can get bleeding and bruising. The more serious complications are you can get bleeding around the heart. Sometimes you may have partial collapse of the lung, but these are things that we are able to handle. And that's why it's done in a place where you have things that we can take care of when these things happen.
So, how concerning it is if someone is having palpitations or cardiac arrhythmia and, any suggestions?
Sure. So palpitations is definitely not a sign that you're having cardiac arrest. You can have palpitations because of many different reasons. So, for example, you could be anxious, or you could be anemic, or you could have thyroid problems, or you could have low potassium, and things like that. They can all cause palpitations. Typically, in a young person who has normal heart, if they are having palpitations and rapid heartbeat, I didn't touch that at all. That is called supraventricular tachycardia, meaning it's coming above the ventricle. Exactly opposite of what we talked today. We talked about tachycardia coming from the ventricle or the bottom chamber. Majority of the palpitations in younger person, I'm talking about 40 and below, is coming from the top chamber of the heart. And those are actually easily curable by procedures called as catheter ablation. And that's what we do majority of the time, go in and try and find where it's coming from and fix that. So the reason for the palpitations need to be diagnosed first and then treated accordingly, because there could be many different reasons why you're having palpitations. In a younger person, it's a different story. Older person, it's a different story.
So it is called PVC, the one which you just
So-
explained.
PVCs can also cause palpitations. So that is a skipping beat coming from the bottom chamber. So palpitations can happen either because your heart is racing very fast or it is skipping a beat a lot. So either one of them can cause it.
The new ICDs, new generation ICDs, are they compatible with MRI?
Yes. I think for the last 10, 15 years, they've been all compatible for MRIs. So you can get MRI with ICD.
How does sarcoidosis predispose you to have?
The sarcoidosis is one of the disease that can be present as with cardiac arrest. It's a very dangerous disease when it involves the heart, because it causes scar tissue in different locations of the heart. It can slow the heart rate too much and cause the heart block where they may end up getting a pacemaker. But majority will get an ICD because they develop a lot of scar tissue within the heart. These are specific medical questions. I'm sure not too many people want to know.
Oh, yeah.
Right.
I think we discussed about sudden cardiac arrest and heart attack. Can you also discuss about myocardial infarction?
So heart attack, technical term is myocardial infarction. As I said, when you have a blockage and the blockage is complete, that is what causes myocardial infarction. And there again, time is muscle. As soon as you have it, you take an aspirin, call 911, and get to the nearest hospital where they can do catheterization and open it up. I think that's the key. Going to a hospital where they can do catheterization and open up the blockage will really help, or it really determines your prognosis, survival, and everything else.
Aspirin usage.
Yes, if you're having heart attack, you should take it. The usage of aspirin chronically in patients who are healthy is very controversial. So if you don't have heart disease, you may not need it. That's what it's coming down to. This aspirin pendulum swings every few years. So when I was in medical school, they said everybody should get it. And now they're saying maybe not. You should only use it in few patients.
You just mentioned young people go through palpitations, which might be due to supraventricular tachycardia. I also know that many young people are going through a lot of stress, which also causes palpitation.
Yeah.
It often seems similar, like how do we differentiate? Is it like persistent? Even anxiety is persistent nowadays.
So that's why I said like there are many reasons for palpitations. The common things are anxiety, thyroid problems, or anemia. Young person, there could be anemic too that's causing it. I mean, if the palpitations are persisting and it's not getting better, the best option for you is to get a medical evaluation because you have to see what the heart rate is, how fast the heart is going. The good and bad is we have wearable technology now, and that's going to help a lot in taking care of patients, not only for cardiac issues, but many other issues. So you will have a decent idea what your heart rate is when you're having palpitations on your Fitbit, smartwatch, or whatever. So then that should help you to guide how soon you should go and get medical evaluation. I mean, typically, when I say young patients who have supraorbital tachycardia, their heart rate goes up to 150, 170, 180, 200, 250 in that range while they are resting and not doing anything.
Diabetic people have any additional risk of developing?
Yeah, I think diabetes because they have increased risk of having heart attack, so they will be at increased risk of having cardiac issues, including cardiac attack. But it's mainly because the risk of heart attack is increased.
So sometimes when we do strenuous workout, often the heart rate raises to 180 or something,
Right.
and it kind of decreases down. But sometimes that heart rate persists to be higher even after a few hours completing the strenuous exercise. Is that does that say there is anything underlying there?
I mean, in a person who has never exercised and starting to exercise, it shows they are probably deconditioned, and that may be why it might be happening. But there will be sometimes patients may have what we call heart rate variability issues, which has to do with your nervous system, how it regulates the heart rate. That can cause your heart rate to come down slower. Again, these things, if it's persisting, you should get evaluated. That's the best way to do it. But the heart rate going up to 180 during exercise in a young person is fine. In general, for us as adults, 200 minus your age is where you want to aim as your top number when you're exercising. I mean, if you go above it, it's not a big deal as long as your condition and everything. But that's generally the number that we look at, or 220 minus age, depending on. But I 200 minus age is also fine. Okay.
Healthy habits to prevent cardiovascular disease.
I think everybody knows that.
I don't know if it's a comment or a question. I just see it.
Yeah, healthy habits. I think now with the chat GPT and all, so many things are available. You can everybody do a Google search, which actually, I mean, almost every patient who comes to us always does some research before they come. So it's a given. I think the healthy habits have been drained into us for a long time. The problem is it's healthy, which is very hard to follow. The common things uncommon to follow, right? So diet, we eat a healthy diet. I think the bottom line is whatever you do, watch your weight. Make sure you're not gaining weight. I think that's a good way you know that you're leading a healthy lifestyle. A regular exercise helps. The exercise is not there for you to lose weight as much. It helps with weight loss, but the exercise also prevents. People have done research a lot. There's a lot of research on these healthy habits, right? For example, I'll tell you, they have done research where if you walk 20 to 30 minutes a day, at least 4 to 5 times a week, you'll live longer, even if you don't do anything else. So those kind of things you should imbibe in your lifestyle. So healthy eating, healthy lifestyle, walking or some exercise regimen is always good. And as you get older, aerobic plus weight training to keep up with your muscle mass and all that is a good thing.
I think exercise by far the best than controlling diet and all that. The best,
exercise is definitely
the
good.
maximum result you can get out of one activity, I think that is exercise.
Yes, but if you're overweight and you have diabetes and things like that, diet becomes very important.
Oh, yeah.
Okay, I think it is,
Yeah. Thank
Because
you.
we can go into the whole cardiac.
Yeah, right.
I know.
Okay.
All right, thank you very much for all your questions. I hope